everybody. Just a little recap. Previous attendees will have seen our slide before, but people often ask, who are the Cancer Alliance exactly? Well, in a way, it's all of us. We're one of 21 cancer alliances in England, and we focus on meeting up the cancer targets for early diagnosis and treatment of cancer, but developing pathways to treatment, supporting research and development, and championing innovation in practice. We cover the 5 boroughs of NCL, and the patients are all of you, ourselves, hospital trusts, local charities, councils, healthcare commissioners, and above all, we're here just to deliver the best care we can to our patient community, and to support improved experience for our patients, and the incorporation of new ways of working, new treatments wherever possible. Thanks very much. And so I'm going to pass over to both Craig and Julie, and it would be wonderful if you could give a little summary about where you've come from, what your particular interests are. I think what we'll do is we've got a couple of, I think I'm going to jump through Catherine, the other slides, and I would suggest in a second we'll just go straight to Craig and Julie. But just before I finish that, to remind people to, if you want to say anything, please pop your hand up. If you think we can't see your hand, please wave. Keep yourself on mute if you're not speaking. And just as we go into the programme, can you show slide number 2, Catherine, just to remind people that what we're facing at the moment is, as a result of COVID, is still a shortfall of over 900 cancers roughly in north central London. And we're running this series partly to try to focus all of our minds on trying to find and pick up those people that at present are lost to the system. Thank you very much, and welcome to Craig and Julie.
Yes, thank you very much. I'll see if I can, I'll just share my screen.
You're going to share your slides, yeah.
Bear with me, and there we go. How's that looking?
That looks fantastic. Lumps, bumps and sarcomas.
That's the one. Yeah, okay. So thanks very much for asking us to present at this meeting. It's great to talk to people in primary care. We interface with primary care a lot. Obviously, we get a lot of referrals through our door, over 100 a week. And this is quite a tricky area, I think, particularly if you're in primary care, to work out which of the many lumps and bumps you see are important. And hopefully, at the end of this talk, we'll be able to answer any questions that you have, and I'll be able to give you an overview of what sarcomas are and what we do in the sarcoma service. I'm going to start off on that topic, and then Julie's going to pick up a lot about the 2-week wait referrals and ultrasound and various other things that are important. So I'm a consultant orthopaedic surgeon at Stanmore, and Stanmore is part of the London Sarcoma Service, which is, as you might expect, the biggest service in the country, and it runs in several hospitals. Most of the medical oncology component is given at UCLH. And I will, so coming up, what is a sarcoma, how to assess a lump, who gets sarcomas, how are they treated, and then managing referrals. So here's a bunch of lumps. One of these is a sarcoma and the rest aren't. And of course, it's quite hard to pick out the one that you might be worried about in the clinic, particularly if you're seeing a lot of people with lumps and bumps. But this is a ganglion, this is a lipoma, this is a lipoma, this is a really big lipoma, and this is a sarcoma. And of course, it's very difficult to tell the difference.
Do you want to just say which ones they are by describing top left, top right, middle? Because if you were pointing at it, people couldn't see it.
Ah, sorry. Okay, so starting top left is top left lipoma, top center lipoma, top right ganglion, bottom left sarcoma, bottom right lipoma.
Right. Thank you.
Let's move to the next one. But of course, you wouldn't really be able to tell what's a lipoma. Benign tumor of mature adipose tissue. So the most common ones you'll see here will be subcutaneous lipomas, which are pretty characteristic on clinical examination. They feel like they're just in the fat under the skin. They feel like fat and so on. And we see those. In fact, we see a lot of subcutaneous lipomas. And one of the issues we have is that we get absolutely overwhelmed with them. And in fact, if you have an ultrasound's a really good test for subcutaneous lipoma, and is also very accurate at telling you what's a subcutaneous lipoma. So those don't need to come for us as a starting point, if you like, but we'll come back to that. What's a ganglion? Well, it's a fluid-filled cyst, usually arising from a joint or tendon, and these are fairly characteristic features of a ganglion. They transilluminate. On the bottom left, they occur around the wrist, and there's a little scar there. You can see they recur after excision. And those, again, confirmed ganglions we don't need to see. We occasionally see the tricky ones. So if you get one from the tibiofibular joint, for example, around the knee, that can cause a problem with the lateral popliteal nerve. So we do see those because of the neurological consequences. But by and large, we don't operate on ganglions. What are sarcomas? Rare malignant tumours that arise from connective tissues, although we usually include nerve sheath tumours as part of sarcoma. So they occur pretty much with the probability you'd expect from the volume of the anatomy. So, we'll see them, for example, in the proximal thigh, where there's a lot of muscle. There's a higher risk of a soft tissue sarcoma there than in other places. It's a very heterogeneous group of tumours. So there's a big, there's well over 100 different diagnoses here, and they occur at all ages. They're rare, of course, so less than 1% of all cancers are sarcomas, and they have the characteristics of other rare cancers, which they are, diagnosis is often delayed, misdiagnosis is very common, it's difficult to get access to the right people, there are uncertainties about how we should treat some of these super rare things. Clinical trials are difficult to organise, although we're pretty good at having huge trials that span several countries. And because of that, survival is often not improving for some of these. How malignant are they? Well, they're kind of not as bad as lung cancer, but worse than breast cancer is kind of where to put it. But if you look at this survival curve for people with bone sarcomas, if you don't have metastases at diagnosis, there's about a 60% chance of being alive at 10 years. And if you do, it's down below 20%. And given that some of these, or a lot of these children, a lot of these patients rather, are in the second and third decades of life, this is quite a significant problem and a disaster for many patients and families. So you'll see very many soft tissue masses, hundreds in a GP career, but you're not going to see many soft tissue sarcomas. And in England and Wales, there are about 1,500 soft tissue sarcomas per annum and about 400 primary bone tumours per annum. It's obviously, of course, important to note that there's about 350,000 cancer diagnoses in the UK per annum, and about 2/3 of these will get bone metastases. And so it's quite clear that the most common cause of a malignant thing in bone above the age of 40 is metastatic bone disease rather than a primary bone sarcoma. And many of these patients are better served by being seen by the local CUP teams, for example, or by their local orthopaedic teams. What causes sarcomas? Most are sporadic. There are some predisposing factors you might look out for: an inherited predisposition, immunosuppression, irradiation. And I suppose the most common example of that is after breast cancer treatment, you might see somebody who's developed a lump in a previously irradiated field. An angiosarcoma or other sarcoma can occur there. Some specific chemicals, so some pesticides, are said to be related. And it can occur at all ages. Here's the incidence by age on the left-hand side of soft tissue sarcoma. So that tends to get more common as you get older. And bone sarcoma on the right, and you'll see a peak around the mid-teens, which is to do with rapid growth. And that's when osteosarcoma in particular would present around the knee or around the proximal humerus, where there's rapid growth. And then there's a second peak later on in life, which is to do with chondrosarcoma, which tends to be a disease of older patients, and usually arises from secondary change in a pre-existing bone lesion. So these patients will present with pain, swelling, often a pathological fracture, loss of use or neurological changes if it's involving a nerve, or as an incidental finding sometimes, although most incidental findings don't turn out to be cancer. And here again is a bunch of patients with different things. So top left, there's somebody with a big lump that you'd obviously be concerned about. That's been growing. It's bigger than 5 centimeters. It feels deep and has in fact arisen from the coracoid. And that was a chondrosarcoma arising in an older gentleman. In the middle at the top, you'll see there's 2 legs. There's some, the clue is the arrow on the left-hand side. This is a child who has a Ewing sarcoma of the tibia, but you'll see some swelling there. And that's what that is. And then just below, you've got two fungating soft tissue masses, both of which are soft tissue sarcomas. And I don't think there'd be much doubt about the fact they would need to be referred and dealt with. And just to show you the kind of range of things that we see and how tricky it is, top left, you've got a tiny spot in a femur there. You can just see, I'll put my arrow on it, although it may not show up. Maybe it shows here actually, yeah. So there's a tiny thing there, that's a nidus for a benign bone tumor called an osteoid osteoma. This classically causes pain at night, is relieved by non-steroidals. And we see those. This is a simple bone cyst in a child, so you can see the growth plates are open. And when this starts to cause pain, it really means there's a risk of fracture, and these can cause significant problems with the hip. Here on the top right, you can just see a soap bubbly lesion in the bone associated with a spiral fracture. So that's been a stress riser, and that's another benign bone tumor called a non-ossifying fibroma that can cause a fracture again in a child. And as you come across here, we've got a lesion in the tibia. A tibia is a classic site for an adamantinoma, which is what that was. That's again a very rare tumor that does metastasize from time to time. Here we've got a bone-forming lesion in the distal radius. This was an osteosarcoma, and there's one here in the proximal humerus, and you can see all the bone formation here. And again, this is an osteosarcoma. And so plain X-rays really remain probably the most useful rapid diagnostic test for somebody with undiagnosed bone pain if you want to exclude a bone tumor. However, as with everything, it's not 100% sensitive, if you like, and so there's some safety netting is usually involved. But by and large, somebody with undiagnosed bony pain does need an X-ray, we would argue. Some things occur in classical sites. So here's a large lesion in the sacrum. This is a sacral chordoma. So somebody with persistent swelling and pain at the tip of the sacrum could potentially have one of these, although they are very rare and again quite slow growing, but that's something to know about. And here's somebody who's had a very large lesion. You can see this in the back of the femur. It looks like a lump of plasticine stuck on the back. And this is a parosteal osteosarcoma, but at the front it's dedifferentiated. So you can see there's a hole in the bone at the front. So this is the kind of patient that will present with a very long history of a lump and perhaps some discomfort in the knee, followed by a change. So the change is really when it's become a malignant tumor. Diagnostic challenges. Yeah, we need to detect these early. Obviously, in an ideal world, we'd see these patients early to avoid delay in their treatment because we think that treatment is likely to be detrimental. But it's tricky, isn't it? Because the wide range of presentations of anatomy and age groups. We, on the other hand, are seeing increasing numbers of referrals. There's a flood of them. And many, and I'm sure Julie will talk about this, third-party providers, particularly for ultrasound, are helpful in providing rapid ultrasound, but not helpful in that they're very often right. I think this is a lipoma, but a sarcoma can't be excluded, which is not particularly helpful, and does stop us doing some of the work we need to do actually for patients who do have sarcomas. Principles of treatment, just in brief, these are conditions generally that need radiotherapy, chemotherapy, and surgery, so it's multidisciplinary, specialist. And because of the wide variety, we come up with individualized treatment plans for patients, which can vary quite a lot. The NICE guidance in 2006 was really helpful in defining what services should look like. And so they're very centralized now. And there are UK guidelines for bone sarcomas and soft tissue sarcomas. So pretty much as you'd expect for most cancer care, sarcomas should be treated by specialist MDTs. And there are some shown on this map here. So down in London, there's the RNOH as part of the London Sarcoma Service and the Marsden. They're two separate services within the same area, and we do talk to each other a lot, and we have shared guidelines and so on. There's one in Oxford, one in Bristol, in Newcastle, Leeds, and so on. So they're fairly centralised, and you can see these are actually the distances that people have had to travel, and so people do go quite a long way to their sarcoma service. This is just a picture of the London Sarcoma Service MDT when we were all allowed to stand next to each other, so it's already a little bit old. Just to show there's a wide range in our team, including radiologists, surgeons, oncologists, pathologists, and so on. And And obviously this is the RNOH, so it's not all falling down. There are some new bits. There's a new bit in Bolsover Street. There's a new ward building up at Stanmore. And just a couple of cases. This is a woman in her 20s who's presented with a swelling in the thigh. You can see that. And that's a synovial sarcoma. So she was treated with chemotherapy, radiotherapy. And this is quite a big tumor you can see in the adductor compartment. And this is the sort of thing that that you must refer, obviously. And this is it just coming out. So we take a big lump out of the leg, obviously, as you might expect. Sometimes this is a child with a Ewing sarcoma of the fibula, so we've done an operation here just to remove it. But that's as part of multidisciplinary treatment. So this patient would have had chemotherapy first and possibly radiotherapy. And we put a lot of implants in after we've taken bits of people out who have had bone tumors, so classically a distal femoral replacement. This is in a young man, again, in his 20s. A proximal tibial replacement we can do custom pelvic replacement as required. And in children who have a distal femoral replacement, for example, an osteosarcoma, we do have a device that gets longer so we can compensate for growth, and this is how it gets longer. There's a little motor in the base of this, and when you put your leg into the device here, it spins the motor and the implant gets longer. So that's been quite a useful thing for some patients. And sometimes we use biology. So this is an allograft. So it's somebody else's bone that's been put into the tibia, that has some cement in it, and it incorporates very well. So there's a variety of techniques that we use for treating patients with sarcoma. But from the patient perspective, these are rare tumors. Patients are often incorrectly reassured, and that can delay their diagnosis. They have to travel for treatment. And there are, as you'd expect, a number of charities which are really have made a huge difference to the treatment of sarcoma patients and have a lot of really good information, both for GPs and for patients about sarcomas. So Sarcoma UK and Bone Cancer Research Trust, and RNOH, we've got Skeletal Cancer Trust, who does quite a lot of work supporting patients. And then afterwards, we talk about survivorship, meaning the lived experience after treatment. It's obviously pretty tricky for patients. The biggest issue really is disability, because you can imagine that after the sort of treatments we've described, people can lose their limbs, or they can have limbs that aren't the same as they used to be. They can have pain and lymphedema, and they obviously need to go into follow-up for long periods of time. And again, some of that we found recently in the in the pandemic, it's really quite helpful for people to have support close to home, where they can, for example, get a screening chest X-ray looking for metastases close to home on a regular basis. That's made a big difference. And like everyone else, we've done a lot more video appointments and so on. So I'm going to hand over to Julie, who's going to talk a bit about referral pathways for sarcoma, and I'll advance the slides.
Thank you. Just before you do that, Craig,
yeah.
I just think it might be easier just to answer if we could kind of split the questions into two halves. So one of our GPs has talked about, should we be X-raying children with unexplained bony pain before we call it a growing pain? And then a comment I put in the chat was particularly that picture, which was in the top left of your screen when you had a collection of them. You could see a very small tumour, and you said that the primary symptom was pain at night. So how do you, just in terms of history and general examination without any imaging, how do you discriminate between bone pain and growing pain? Any tips at all?
I mean, growing pain is an interesting one, because it's fairly it's quite a common story, actually. People
very common from our perspective.
Yeah. I think the one thing that's clear is unilateral pain. I think you should probably not dismiss as a growing pain, I would say. Unilateral pain would need an X-ray.
Although a lot of children wouldn't describe their growing pains as bilateral.
Yeah, so I think that's quite difficult.
It's kind of really hard.
And to be honest, it's not a diagnosis that I make as an orthopaedic surgeon. It's something that you'll see in primary care. So it's quite difficult for me to say, except that obviously we do see people who haven't been examined, for example. So I'd say a clinical examination would be really important. And I think it's not, you guys know all about safety netting, and I think you just want to be absolutely sure that you had that diagnosis right, I would say.
Yes.
The general message from the ivory tower, if you like, is that undiagnosed bony pain needs an X-ray. It's just, I guess, at what point you say, actually, that's not diagnosed. At what point? I mean, I suppose growing pains, certainly if you're in hospital, growing pains would be a diagnosis of exclusion, wouldn't it?
Exclusion. I think. Tal might want to speak to this because he was the person that posted the first question. But certainly from my perspective as a clinician, it perhaps, if we're trying to find ways of guiding people, perhaps it's to do with chronicity or non-chronicity of the symptom. So does sarcoma, when it starts to hurt, continually hurt, or does it does it go away and come back again, or does it just go away with a bit of Calpol? So how can we discriminate early on? Because we can't X-ray all. If we X-rayed all children who complained of non-specific pain that the parent probably is presenting with, is this growing pains, we would probably have a call from the CD of radiology to start telling us that we were overexposing people to radiation. It's really common. Tal, do you want to say anything further?
Thank you. No, I think it's really useful, and certainly if it's a unilateral pain, I think examination, and then if you have any doubt, I think obviously when they come to tertiary care, these are the cases that we might have missed, and you see just a segment of the population. But I guess for our own safety and for our patient safety, we should probably X-ray if it's a unilateral pain that doesn't go after a week or 2 or 3. Maybe we should consider X-raying it then.
Yeah, I think so. I mean, certainly, in orthopedic practice, it's look, feel, move X-ray. And so for musculoskeletal things, I think we've got a low threshold for X-rays, and it's a low dose of radiation. And if it's not just sarcoma you're looking for, of course, there's a whole bunch of things you might see on X-ray that you just wouldn't pick up otherwise.
So Tal talked about persistent over 2 to 3 weeks. How does that feel comfortable for you, or is that too long?
No, I think, well, one has to be sensible, don't you? I mean, I think 2 to 3 weeks sounds very sensible, actually. If you've examined the patient and they're otherwise well, and there's nothing else to find, then that seems like a reasonable safety net, I would say. I mean, there'll be some patients, if you find a lump or there's a swelling around the knee, for example, then you would certainly want to X-ray them faster. And of course, the other thing is, have you got hip pain? Have you got something in the hip that's causing knee pain? These things are difficult, aren't they, if you don't have ready access to X-rays? And these are all patients who would, if they came to an orthopaedic clinic, get an X-ray as a matter of course,
once they've got that far. Do you think a lot of patients are being seen initially with video consultations? So I'm presuming that you've said you talked about history, feel, so look, feel, image. Do you feel that I'll take a straw poll from the people on the call today. How many people are referring for X-ray with just a video consultation as opposed to palpation? Because that's something which faces people. It's a challenge for primary care at the moment. Not necessarily always being able to bring everybody in, but clearly examination is more than just the visual examination.
Yeah, I'd agree with that. I think it's really hard to do that by video. I mean, video is good for some things, isn't it? But I think if you see somebody and you're on a video call and you're sufficiently concerned, then yeah, you need to see them face to face. Although I have done a fair number of people. I've had people showing me their knees and their ankles and this sort of thing on video calls. And their hands in particular has been surprisingly useful. But I think sometimes you've just got to see them, haven't you?
Sure.
Some that have to come up.
And the case history slide that you showed up with a woman in her early 20s that had a thigh tumour. What did that feel like? You showed a picture of pre and post. Well, pre-surgery. What did that look like?
It's a large, deep mass in the thigh, and as a synovial sarcoma, they're often, again, they're tricky. They can cause pain for quite a long time. They can be slowly growing. Hers was more rapidly growing and was causing a painful lump in the thigh, but not all sarcomas are painful. And I guess that goes back to your question about pain history. What features are important. And of course, it's difficult because they all vary. But classically, night pain is the thing that we talk about.
Right. Thank you. And Julie's put something really important in the chat around number of visits reflecting concern, and I think that's absolutely true, Julie. And I think anyone on the call would agree that if people are repeatedly presenting, then clearly there's something going on that needs further assessment or investigation. That's a good segue into Julie's part of the talk. Thank you very much, Julie. We'll move on to you. Thank you.
Thank you. I'm going to sound a bit Chris Whitty. I'm going to ask Craig to move the slides on. So I'm just going to run through what we've seen during the last 12 months. Obviously, we've all had a very unusual year. We've definitely seen changes in our referrals to the service. But equally, prior to COVID, we were struggling anyway around the volume of referrals we were getting. As Craig said, we are the London Sarcoma Service. We support referrals for bone and soft tissue sarcoma. The Marsden treat soft tissue sarcoma. So for London and the southeast of England, we take the bone sarcoma referrals. So our patients are coming sort of as high as Northampton down to sort of Brighton, across to Essex and towards Oxford. So patients come a huge distance, and actually COVID has possibly really offered some opportunities for how we might manage patients in the future much more remotely than we had been previously. So there will be some changes in practice that will come out of this year for the good, but our patients do come far and wide. So although we're talking to you as a group of GPs, we receive 2-week waits from all over the other alliances. So if I just go to the first slide, you can see that the numbers of referrals we've had during the last year, we had a huge dip, as you might expect, at the beginning of the year in wave 1. On average, before then, we were getting sometimes up to sort of 500-600 referrals in total to the service. That's both from primary care, inter-consultant referrals, and obviously from secondary care. One of the problems we were having prior to COVID was lots of referrals coming off ultrasounds that would recommend an MRI scan. And then obviously some of the limitations, it seems quite variable about which GPs can access to MRI and which ones can't. And so we were having some discussions, particularly around InHealth, around some of their reporting that very much left probably GPs in quite a difficult position of not really being able to not refer on because of the way the report was written. So on the next slide, we talk about where the referrals have come from. So if you can forward on. So we track all of the referrals, and in the bottom column, at the bottom of the column in the blue, is the GP ones. We know that our conversion rate on a 2-week wait referral from primary care is low. Historically, that has been about 3% for a conversion to a sarcoma and about 12% to a cancer diagnosis. We know that most patients, unfortunately, are referred after quite elongated pathways through presentation to orthopaedic services in local hospitals. The next slide goes on around goes on to just highlight, as you said, the missing patients this year. So the green line highlights our previous sarcomas diagnosed each month, and then the red and the blue are highlighting this year. So we have seen a huge drop in the numbers of sarcomas that we've diagnosed during the last 12 months. We haven't really sort of felt at the moment that we're seeing patients presenting with advanced or metastatic disease, but we are alert to that and talking about that in our MDTs. One of the COSD data requirements that we're asked to collect is about the number of visits that the patients presented to the GPs with, and also the duration of symptoms that the patient has noted. The next slide really is just to highlight the guidance. We have recently, in line with some of the practices that the Marsden have been doing, is triaging our 2-week waits. Historically, we had a fairly open door policy and pretty much accepted all referrals. What we were seeing was lots of patients referred with no imaging, lots of patients having to travel huge distances to have an ultrasound. And so we are now being slightly stringent about our triaging, and where patients haven't had a referral for any imaging in primary care, we're asking that the GPs call and discuss their concern. We have noticed, particularly in NCL during the last 6 to 8 months, that more and more GPs have said they haven't had access to urgent direct booking ultrasound, and we've been flagging that with NCL. And so what we have noticed by triaging and in particular redirecting referrals when clearly patients are presenting with metastatic disease as a first presentation, and suggesting those patients are managed through a CUP team, is that our conversion rate has increased, and we're now up to about 7%. So we are not at all trying to be difficult, but really trying to make sure that we've got the resources to really get the patients fast track through their pathway when there is a high suspicion of sarcoma. The BSG, the British Sarcoma Group, because this has been an ongoing problem over the years, we have noticed, and as you guys will also probably have noticed, that lots and lots of ultrasounds are now reported by sonographers. And so the next slide just highlights the BSG guidance around training for sonographers and training for reporting a ultrasound of a soft tissue mass. We're getting lots and lots of, or had been certainly getting lots of ultrasounds that left huge riders, as Craig says, that reports that this is likely to be a benign lesion, however, can't exclude a cancer, and then that obviously leaves everybody hanging. Have we got stuck on that last slide, Craig? Yeah. So on the new referral guidance, and interestingly, I did go on to the NCL referral and checked it all out last night. It does refer you to an old edition of the London South East Sarcoma Network guidance, so that's something we've picked up. But there is a link to the BSG guidance on ultrasound that we, as two sarcoma services, both us and the Marsden, are aware that we need to develop better advice and guidance and give clearer guidance around supporting and holding patients with benign tumours, and really stop some of those referrals that are coming on to the sarcoma centres. So the BSG guidance, we can send a link later. That's a really good document that just gives the information on how ultrasound should be done and where the triggers are to consider a referral onto a sarcoma centre, and where patients could be referred locally for benign soft tissue tumours. Finally, the next slide just picks up on the CUP and MUA referrals. And again, that seems very variable, and we're talking with NCL about that. So we're keen to make contact with the CUP leads. We get lots and lots of patients that have presented with bone pain, had an X-ray, and there's a aggressive looking bone lesion. Often patients have had a history of breast cancer or prostate cancer, but the referral is coming through to us as a sort of presentation of a new concern. And so if we're able to, we want to work much more closely with the CUP teams for managing patients. What we have seen in our breach data recently is when we have taken on a referral which clearly wasn't suspecting a sarcoma but suggested there was a malignancy, we are unfortunately causing quite substantial delays to that patient. We might perform a biopsy, but there's still no primary cancer detected, so then patients are referred on to a CUP team. The histology needs to be transferred and reviewed, and often they are the patients that we're seeing breach on our intertrust transfers. So I think we are keen now to try and redirect those patients earlier on in their pathway. And then finally, it was really just to take the opportunity with you, because we rarely get to speak to any of our primary care referrals about the challenges you have, what advice we could give. As I said, we know we need to improve our advice and guidance. We have adopted a consultant of the week model in our service, so there is access to a consultant if there is any question about the appropriateness or concern about a patient that you're keen to refer. The Sarcoma Advisory Group, which is the meeting we hold with the Marsden and all of the commissioners, we're looking at 2-week waits to make sure we're consistent across the whole patch, and also to develop some advice and guidance for GPs. And as I said, we really want to work with the CUP teams to stop patients having elongated pathways. So happy to take any questions, but really it was to sort of hopefully get some discussion going about how we can make sure we don't miss patients, but equally how we can ensure that the referrals are appropriate, really.
Thank you. Thanks very much, Julie. I'm going to open this to questions. Does anybody have any questions they want to ask? Please wave or pop your hand up, ideally, while we're waiting for that. So one of the challenges we've got at the moment is that CUP services across the whole of the NCL geography are variable. And at this very moment, it's in terms of availability of referral forms and the cohesiveness across the system, the access to an RDC would be easier for the GPs in our area. And in fact, Akasha, there's a note that Akasha has just put in the chat about would we refer to CUP or RDC. So can I ask what dialogue you've had with the local RDCs, which would for you be North, Mid or UCH at the moment, and Royal Free are planning to come online this month, in fact, later this month?
Yeah, so I was looking around, as I said last night, at the pathways, and as you said, the CUP teams seem very variable, and even when we've tried to interact, the receptiveness has been quite variable about whether they would take a patient or we should continue with a patient.
Yes.
So the RDC, I mean, I was looking at the guidance last night, as you say, at UCL are open. My understanding is it was sort of much more looking towards bowel, making sure that bowel cancer pathways are much quicker. So we haven't had any communication with the RDC centre at UCLH. So that was a bit of a learning for me last night. No, so I think that is something we need to
if I
make
take
that
away
connection.
from this, that we can, from the Alliance perspective, we'll make that happen. And I think actually what would be good is to be able to say something to GPs on the call today. So I'm going to take responsibility for this, but what I'm going to say, and I will speak to the RDCs, both of the functioning ones, when this call ends. But at the moment, which is 1:09 on the 6th, can I say that if you've got a concern, then please use the RDC form, because that is a form that we have across the whole of North Central London. And I will speak to the 2 clinical leads when this call ends. And I know they're always keen to support ultimately early diagnosis in cancer, so they won't have a problem with that. And when we are able to reach a cohesive approach from the CUP services across our providers, then we might revisit that. But we have been trying, and different teams have very different views at the moment about how they can best manage their own services. And so Julie's absolutely right. We can't give you a single decision on that. So I'm going to say the RDC, unless Craig, you want to say anything else. Look, I shouldn't say that in the short.
I mean, early discussions that I've had about RDCs are exactly as Julie said. They're about colonoscopy and things like that, and and musculoskeletal cancer does seem to me to be quite far down the list of concerns.
So, yes, although the RDCs are different from the MDCs, which were multi-diagnostic centres and existed before COVID, and they were very much organ specific or kind of parts of the body, abdomen specific often. But the current RDCs are expecting, certainly in our patch, we are keen to offer a holistic service, and if we will redirect if something is incorrect or refer on, rather than we don't wish the RDC services, and neither do the clinical leads for those two services wish to be a barrier to people contacting for expert advice. So I think we will take it that way around now, because I don't want to end the call. It's not practical if we can't come to a solution. We've got you know, sort of up to 30 clinicians on this call, and we don't know what they're going to face when they open their casebook at 2 o'clock, 1:30. So I think we need to make a pragmatic decision and say, I'm going to say use the RDC form, and then we, as things change, things might be different. Clearly, Craig, if there is a GP does an image and the diagnosis is obvious at that time, then referral straight through to you.
So it depends a bit. If you think it might be a new presentation of metastatic bone disease on an X-ray, then they need to go to the CUP team, or perhaps the person who looked after them for breast cancer. Yes. Or even, you know, orthopaedic services should have a metastatic bone disease lead as well. And for most patients, it's better that they get that treated closer to home. And there are a number of people who have an interest in that dotted around the area. So that's useful. So, but if you had, for example, an X-ray of concern in a child, then yeah, we'd see them straight away. And that's how the pathway works, generally speaking.
And certainly the children that I've personally had to deal with, you've always seen them immediately.
We'll just do that. And I think there's a 48-hour target, or there was certainly for seeing them in clinic. Yeah.
Absolutely. Yes. Does anyone have any questions on that particular topic? Has this raised any queries? Or are you feeling happy about it? At least okay at the moment? You can yell if you like. Take yourselves off mute. Okay, so I'm going to take silence as people are kind of clear about that in the short term. Okay. Any other questions? Sorry, Craig.
I'm just going to say, great to have it as part of an RDC, and we can certainly work out the protocols and what might be done in that centre before referral onwards. That would be fantastic, actually. Yeah. We see other things quite a lot. We see lymphomas quite a lot, for example, and we see myeloma, and these, you know, that need to go to haematology. So maybe, you know, maybe getting to the RDC first would allow a bit of triage there and signpost the appropriate service quickly. That'd be great. Fantastic.
Yeah. Okay. Thanks, Craig. There's a question that's just come into the chat about, just to confirm, regarding paediatrics, they do not need a scan. Let's have a look at the full. Do you want to, Kasia, do you want to speak your question?
Yeah, so just wanted to confirm. I missed what you said towards the end. So if a child, if the history is worrying and the clinical examination is suggestive, would I then refer down the route of getting a scan done and then referring to you, or can I just refer?
I mean, in practical terms, what sort of scan would you have access to?
So we have some access to some urgent scans. I have to go through it, whether we have the 2-week scans as well available to us, but I have to go through, I don't remember on the top of my head exactly.
So in this situation, Kasia, it would probably be an urgent ultrasound. And that's on a 2-week turnaround. So in children, one will probably want to act quicker than that. Yes. To be honest. Craig, yeah. Julie?
Yeah, my understanding is that the standard is different for children in terms of direct X-ray and ultrasound for children if you suspect, and then obviously into paediatric oncology services. So for adults, according to the guidance, it's obviously direct access within 2 weeks, but for children, it's 48 hours.
Okay, thank you.
So you could use that form and expect that turnaround, but I think you would need to have a safety net, perhaps an electronic safety net in place, Kasia, so that and certainly be very clear with the parent, so and have a way of a guaranteed way of them feeding back to the practice immediately if they weren't able to secure the image. The other thing I would raise that sometimes happens, and it's very it's probably person specific, Julie and Craig, is that occasionally radiology will say that they want a request for an ultrasound for an X-ray for a child to go via PEDS, which obviously doesn't fit in with any of the timelines we've discussed. I've seen less of it recently, but recently I mean during COVID, but it does sometimes still happen. I'm presuming you have dialogue with the radiology colleagues across London about how how they respond to these sorts of requests, or why they wouldn't be saying that anymore.
I don't think I've had dialogue like that for example, you would refer to a local hospital and it would be their guidelines, presumably. I mean, I don't know. I think that's quite tricky. You then need another route in if you're concerned about them. And I guess, although, the other observation is that because we get so many referrals of people with benign conditions, the kind of morbidity of that is quite significant, actually, for patients, most of whom turn out to have something benign. We see quite a lot of pretty stressed out patients on two pathways with benign disease. So I don't know. I mean, clearly one doesn't want to miss pediatric cancers, but I think the way in which they get referred on the two-way pathway is also quite important, isn't it? Because most people we see don't have sarcomas, of course.
Yes. Yeah. Yes. Okay. So so basically, going back to Akasha's question, so do children need a scan if the clinical presentation is worrying? Sorry, is that what you're saying? They don't need a scan? Sorry, actually, I think the way you've put it in, Akasha, so what you're saying, did you mean to refer without an image? Don't know if she can still hear me. Yes, she says. Yeah, so then so I think my question to both of you is, from Akasha, are you happy without an image, or do you still want an image requested on a 48-hour timeline?
I mean, I think if you're worried about a child and you can't get an image, then you should, quickly, then we will see them, or they should be referred to pediatric oncology if there's an obvious lump, or to our service is fine. Yeah. And we would sort of see them quickly and sort them out.
In terms of the forms that people would have, unless they were referring straight into pediatric oncology via A&E, then the form, in fact, would be via you.
But I guess, I mean, it would depend a bit on your level of suspicion and the length of the history and that sort of thing. But if you're you're seriously concerned and you want to sort it out quickly, we would do that. Yeah.
Would in fact then the best thing to say be, Julie, you talked about a clinician of the day. Is in fact the best thing to call the clinician on the day?
Yeah, I mean, that's available through Switchboard. So I think if you're concerned and you're struggling to get the X-ray, then absolutely just speak and get speak to our guys and get the advice. Okay,
so is it the clinician of the day or the sarcoma clinician of the day, or what?
We have it as consultant of the week, and that's available via the Switchboard. But we are doing lots of changes to the sarcoma London Sarcoma Service website, so again we can sort of make that much more visible on the website.
Yes, and then once you've made your changes, could you communicate that with us, if we speak outside, but just so that we can link that in with NCL's new website for GPs?
Yeah.
Can I just ask a bit about advice and guidance and how that fits in?
Yes.
So can you use that instead, or is that?
So we can use advice and guidance, and you can also so you can use advice and guidance, and you've got the option to tick to say that you're happy for the consultant concerned to do an upgrade, and I think it'd be interesting to find what. So some people get really quick responses to advice and guidance. Other people get much longer responses. So that's the difficulty. And Saloni's put in Saloni, would you like to ask your question?
It wasn't a question. It was just to say that the PEDS urgent referral team, which are accessible via Switchboard, are very useful at differentiating whether you need to scan or not. So they're a good port of call for a GP to call quickly. I was just highlighting that.
Yes. Okay. Thank you. Yeah. So right, and that's the lunchtime clinic. Is it the one that you're referring into the lunchtime clinic, or they just take the referral and deal with it on a case by case?
It's an email referral, and you can also ring the consultant on call. It's both at Barnet and Royal Free at the moment.
Okay, thank you.
That sounds very sensible, because the vast majority of them won't have a sarcoma. So That seems very sensible. Yeah, yeah, support that.
Yeah. Okay. Thank you. Thank you.
Whilst we've had an opportunity to talk to you guys, so one of the things we've done during COVID is obviously in terms of follow-up, we've been asking GPs to help us with imaging for follow-up, and actually lots of patients that's worked really well. Do you think there'll be an opportunity for some of that practice to continue? So our patients, once they've been treated, to manage their risk of distant metastases, they have regular chest x-rays. And so we have found lots of GPs helpful in organising a chest x-ray locally, and then we can get it retrieved and reviewed in our service and then hold a telephone follow-up with the patient. And I assume that people were being helpful and it was a needs must because of the pandemic, but is that something you might see continuing, that we would continue to approach GPs for that sort of support?
So I think that primary care would like to say yes, but the problem we've got is that primary care overall is having that request from almost all specialties in hospitals at the moment. And I think what primary care would what one would prefer would be that you would be able to do the ordering yourself. So actually, if you want to craft an email to me, we've got an NCL diagnostics.
That would be a dream.
We've got an NCL diagnostics board tomorrow morning, and if you could, if you wanted to send that across to me, I'll ask formally about how that could happen, because we need to sort the tech out about that.
I mean,
sorry, yeah.
Across NCL, it's not too bad because geographically the distance isn't great, but obviously, you know, we've done that with lots of other GPs further afield, yes. And it was just whether you've had a sense that that's going to continue as we get back to normal.
So there's lots of dialogue in GP press about the fact that the GPs are having real difficulty with the people have looked at GP activity. At the moment, it's running up to 20-25% more than pre-COVID. So it's something that I know that people are finding difficult. I would worry about speaking for GPs outside our patch. Yep. But I think logically, it seems entirely reasonable. But it's how of course, we want people to be imaged locally to them. But it's whether we could sort out the nuts and bolts of requesting to make that easier. I think the other thing that GPs are worried about, different GPs would have different types of safety netting mechanisms for communicating that report. So part of this will depend on how if you're happy to be the people that are responsible for the report, or if you want the report to go back to you from the radiology department.
Yeah. Okay, thanks.
Thank you. Any other questions for us? Or for you, for Craig and Julie,
or for us.
For us. Yeah, for you to ask us. Not yet. You could always ask us later. Okay. All right. I think that it's been really helpful, and I think that people find images, kind of seminars with images can be really, really helpful. So it was great to have the pictures that you included, and I'm going to ask whether people would like a follow-up session, particularly aimed at children, that was more about a set of slides and some case histories. So if you could pop in the chat if you think that will be helpful, then we'll bother you again, Craig and Julie, to see if you could come back and talk to us. Okay, so yeah, I've got people already saying yes, please do it. So and maybe it shouldn't just be children, but maybe just a session of pictures and stories would be really helpful. Picture, stories, and also something about how it feels when you hold that lump. How does it really feel? Would be very helpful. And one other query, perhaps. We have a mixture of imaging offered to us at the moment in NCL, either local imaging at local trusts or in health, and different people in health seems a bit like Marmite in terms of responses for people. So, and can you please give us a direction about that? Do you feel there? So quite often the trust will say that the reporting feels distant and variable from their own in-house reporting, for example. So just anything you can, would you prefer us to refer at this present time to our local trusts?
So we've been having this discussion for some time. We have had problems with in-health ultrasounds, particularly leaving the option of not referring closed. I mean, they just put a rider on the bottom. So we've been sharing the BSG guidance on ultrasound reporting within health. And then through discussions with the Transforming Cancer Services team, my understanding is that in health, particularly as we come out of the pandemic, aren't used for direct access imaging from primary care. So
and not used or are not used?
Aren't used.
Aren't used.
They're not. So if you suspect cancer, the imaging request shouldn't go to in health, is what I'd understood from the Transforming Cancer Services team.
So if I think what I would say is, if you, to the clinicians on the call, if you suspect cancer, then you're completely within your rights to use that urgent imaging referral form, and that's that is only for our trusts, and that's on in the sort of cancer -2 week wait folder on Bar Global of EMIS, the clinical platform that GPs use. So that would then obviate that. Then that definitely will bypass in health in that way. Yeah. So perhaps if we're taught that the message is, if you think this might be sinister, then use that method of getting an image. At the moment, because we haven't yet recovered our scanning capacity in general across NCL, it at least will also guarantee that turnaround of 48 hours for children and 14 days for adults. There's a question here. Michael, would you like to speak your question and give a bit more detail, or shall I just read it out? Read. Michael said, are you able to review indeterminate ultrasound scans? So I'm guessing that means we get a report back. We don't understand the report because it's a bit of this, a bit of that. If you're worried, do this. If you're not worried, do the other. Or can't exclude is a good phrase that worries us as clinicians. So what do we do then?
I think you can to an extent, but it does depend sometimes. I mean, the usual thing is a subcutaneous fatty lump, and so subcutaneous lipomas are, I would say, and it's once you never say never, but never malignant, pretty much. It doesn't matter what size they are, and that kind of runs counter to most guidelines about size. But so an ultrasound is a really good test for that. And when we put the British Sarcoma Group guidelines together, actually for ultrasound, nobody in the country could remember seeing a subcutaneous lipoma that subsequently turned out to be malignant. And so with those, the risk of malignancy is very small. And so what we'd recommend is that they go to a local plastic surgeon or general surgeon for further evaluation. And they don't have to come to us. And the difficulty there is that there'll often be the rider, as Julie puts it, at the bottom to say we can't exclude it. So an ultrasound scan that is kind of saying that is enough for us. And in fact, the Marsden, they would screen they just read all the ultrasound reports and reject a load on the basis of that. We're a bit more cautious about it, but there are some where you clearly think, actually, do you know what? That just needs to go to a local place. The chance of it being a sarcoma is so small, it doesn't need to come to us. And actually, one of the rationales for coming to us quickly is because the way in which you manage it is important. If it turns out to be a sarcoma, the way in which you subsequently excise it. But for subcutaneous tumours, that's much less of an issue. So for some of these, we think they should go to local services and are more appropriate than coming to us. But we do take it with a pinch of salt. And the problem within health is not so much the accuracy of the scan itself or the first paragraph or two. It's really the caveat at the end that makes it really tough.
Yeah. Okay, but you can't easily access their images at the moment, can you, directly?
Well, if you ask the radiologist, they'll say an ultrasound's a dynamic investigation, and
Right.
you know, it's got to be done on. There are pictures to look at, and they're sometimes helpful, and they have sizes on and depths and things. But actually, it's a dynamic sort of thing.
So in practice, the answer to Michael's question is no. Can you review indeterminate ultrasound scans?
Yes, I guess it depends. This phrase indeterminate, the word indeterminate covers a lot of ground, doesn't it? So it depends.
Yeah.
It depends.
Okay, thank you so much. Okay, so on that depends note, we'll end this this session, because you're coming back, both of you, from by popular request, and I'd like to say thank you very, very much for coming this afternoon, and we'll look forward to another a session with lots of pictures, and we'll diarise that and advertise that for everybody, and anyone who's already registered with us, and you obviously are, if you're on the call today, you'll get that diary invitation going straight in to your MS Teams diaries. Thanks very much. Outlook diaries, in fact. Thanks to both of you, and thanks to our Alliance team today. Bye bye.
Cheers, bye.
Bye bye.